Long after an acute infection has cleared a patient's system, their heart can actively continue to destroy itself. The cascade is initially triggered by acute rheumatic fever. Before the damage sets in, healthy heart valves maintain a flawless seal with every heartbeat. But on a microscopic level, fibrin and blood cells accumulate along the borders of the valve leaflets, and these clusters slowly harden into rigid, opaque scar tissue. As the acute inflammation of the fever subsides, these initial lesions do not heal. Instead, they permanently deform the underlying tissue. What began as an immune response shifts into a problem of physical deformation, converting the heart from an efficient pump into a mechanically compromised system. This scarring process zeroes in primarily on the mitral valve. The damage heavily targets the endocardium, altering the valve leaflets and the fibrous strings of the chordae tendineae that tether them. Every subsequent attack compounds this damage. The chordae tendineae severely shrink and thicken, while the leaflets become rigid and fuse at the edges. The aortic valve is the second most common structure to undergo this exact same deterioration. A rigid, thickened mitral valve can no longer maintain unidirectional blood flow, creating a ticking time bomb for the rest of the cardiovascular system. This scarring leads to the first of two distinct hemodynamic profiles: mitral insufficiency. Due to the loss of valvular substance and the severe thickening of the chordae, the mitral valve can no longer close completely. When the left ventricle contracts during systole, this incompetence forces a large jet of blood backward into the left atrium. The left ventricle now has to manage a massive volume overload, pumping both the normal incoming blood and the blood it just regurgitated. Over time, the ventricle forcibly enlarges and its contractility drops. Mitral insufficiency traps the heart in a futile loop, constantly overworking the left ventricle just to maintain baseline output. The second pathological pathway, mitral stenosis, develops much more slowly, often taking 10 years or more to fully manifest. Here, the mitral ring undergoes severe fibrosis. Commissural adhesions cause the edges of the leaflets to physically fuse together, leaving only a tiny, rigid opening. During diastole, this narrow orifice creates a severe physical obstruction to the normal forward flow of blood from the left atrium into the left ventricle. Trapped behind this barrier, blood pools in the left atrium, forcing the chamber to work against extreme resistance and generating a massive pressure gradient. Insufficiency drowns the heart in excess volume, while stenosis crushes it under excess pressure. Yet both mechanical defects trigger the exact same backward cascade. Whether from regurgitation or stenosis, the immediate convergence point is left atrial enlargement. From the distended left atrium, this elevated pressure travels backward, moving directly up the pulmonary veins and saturating the lung fields. This elevated pulmonary arterial pressure leads to severe congestion in the lungs, manifesting clinically as orthopnea, extreme shortness of breath, and hemoptysis, or coughing up blood. The cascade doesn't stop in the lungs. That congestion creates an unsustainable workload for the right side of the heart. The right ventricle and right atrium sequentially enlarge and collapse, resulting in terminal right heart failure, marked by an engorged liver and severe swelling in the legs. A microscopic scar on the left side of the heart inevitably dictates the complete mechanical failure of the right side, driven entirely by fluid dynamics. Clinicians can detect this profound physical stretching of the left atrium before ever looking at an ultrasound. This ECG reference chart illustrates the P wave, the direct electrical footprint of atrial depolarization. In a healthy heart, the right atrium depolarizes slightly before the left. Lead 2 records this as a single, smooth, blended wave. Under the pathology of rheumatic left atrial enlargement, that signal fractures. Lead 2 displays a distinct notched wave. Because the rheumatic left atrium is physically massive, its electrical signal takes significantly longer to travel across the tissue. It visibly separates from the right atrium signal to create this bifid shape, known as P mitral. Shifting over to lead V1, we see a deep negative deflection. The sheer mass of the enlarged left atrium pushes the overall electrical vector posteriorly, pulling the signal aggressively away from the chest lead. The classic P mitral ECG finding is a literal geometric shadow cast by the structurally failing left atrium. If the primary rheumatic insult extends to the aortic valve, the resulting aortic insufficiency drastically compounds the left ventricular dilation and hypertrophy. This specific regurgitation generates a vastly widened pulse pressure and bounding peripheral pulses. Medical management of rheumatic heart disease attempts to artificially manipulate these broken hemodynamics. ACE inhibitors reduce afterload, the resistance in the peripheral blood vessels. Decreasing that resistance allows more blood to flow forward, temporarily reducing the regurgitant volume and preserving left ventricular function. While medications can manipulate the fluid dynamics for a time, they cannot fix the underlying structural barrier. Because rheumatic heart disease is ultimately a physical deformation, definitive treatment requires physical anatomical correction. Surgeons must intervene directly, either by cracking open stenotic adhesions with a balloon mitral valvotomy or by performing a complete surgical valve replacement. A microscopic inflammatory scar on the mitral border acts as the catalyst for decades of irreversible volume and pressure overload. By tracking the initial mechanical insult of rheumatic heart disease, every subsequent clinical finding, from pulmonary hemoptysis to a notched P wave on an ECG, becomes entirely predictable.